UTI in pregnant women. Nitrofurantoin, ampicillin, and cephalosporins are considered relatively safe in early pregnancy. Association between
nitrofurantoin and birth defects has not been confirmed. Sulfonamides should clearly be avoided both in the first trimester, because of possible teratogenic effects, and near term, because of a possible role in the development of kernicterus. Fluoroquinolones are avoided because of possible adverse effects on fetal cartilage development. Ampicillin and the cephalosporins have been used extensively in pregnancy and are the drugs of choice for the treatment of asymptomatic or symptomatic UTI in this group of patients. Generally, pregnant women with ASB are treated for 4 to 7 days in the absence of evidence to support single-dose therapy. For pregnant women with overt pyelonephritis, parenteral beta-lactam therapy with or without aminoglycosides is the standard of care. UTI in men. Since the prostate is involved in the majority of cases of febrile UTI in men, the goal in these patients is to eradicate the prostatic infection as well as the bladder infection. A 7 to 14-day course of a fluoroquinolone or TMP-SMX is recommended if the uropathogen is susceptible. If acute bacterial prostatitis is suspected, antimicrobial therapy should be initiated after urine and blood are obtained for cultures. Therapy can be tailored to urine culture results and should be continued for 2 to 4 weeks. For documented chronic bacterial prostatitis, a 4 to 6 week course of antibiotics is often necessary. Recurrences, which are not uncommon in chronic prostatitis, often warrant a 12-week course of treatment. Complicated UTI, other than that discussed above, occurs in a heterogeneous group of patients with a wide variety of structural and functional abnormalities of the urinary tract and kidneys. The range of species and their susceptibility to antimicrobial agents are likewise heterogeneous. As a consequence, therapy for complicated UTI must be individualized and guided by urine culture results. Frequently, a patient with complicated UTI will have prior urine culture data that can be used to guide empirical therapy while current culture results are pending. Xanthogranulomatous pyelonephritis is treated with nephrectomy. Percutaneous drainage can be used as the initial therapy in emphysematous pyelonephritis and can be followed by elective nephrectomy as needed. Papillary necrosis with obstruction requires intervention to relieve the obstruction and to preserve renal function. Asymptomatic bacteriuria. Treatment of ASB does not decrease the frequency of symptomatic infections or complications except in pregnant women, persons undergoing urologic surgery, and perhaps neutropenic patients and renal transplant recipients. Treatment of ASB in pregnant women and patients undergoing urologic procedures should be directed by urine culture results. In all other populations, screening for and treatment of ASB are discouraged. The majority of cases of catheter-associated bacteriuria are asymptomatic and do not warrant antimicrobial therapy. Catheter-associated UTI. Multiple institutions have released guidelines for the treatment of CAUTI, which is defined by bacteriuria and symptoms in a catheterized patient. The signs and symptoms either are localized to the urinary tract or can include otherwise unexplained systemic manifestations, such as fever. The accepted threshold for bacteriuria to meet the definition of CAUTI is greater than or equal to 103 CFU/ml of urine, while the threshold for bacteriuria to meet the definition of ASB is greater than or equal to 105 CFU/ml. As catheters provide a conduit for bacteria to enter the bladder, bacteriuria is inevitable with long-term catheter use. The typical signs and symptoms of UTI, including pain, urgency, dysuria, fever, peripheral leukocytosis, and pyuria, have less predictive value for the diagnosis of infection in catheterized patients. Furthermore, the presence of bacteria in the urine of a patient who is febrile and catheterized does not necessarily mean that the patient has CAUTI, and other explanations for the fever should be considered. The etiology of CAUTI is diverse, and urine culture results are essential to guide treatment. Fairly good evidence supports the practice of catheter change during treatment for CAUTI. The goal is to remove biofilm-associated organisms that could serve as a nidus for reinfection. Pathology studies reveal that many patients with long-term catheters have occult pyelonephritis. A randomized trial in persons with spinal cord injury who were undergoing intermittent catheterization found that relapse was more common after 3 days of therapy than after 14 days. In general, a 7 to 14-day course of antibiotics is recommended, but further studies on the optimal duration of therapy are needed. The best strategy for prevention of CAUTI is to avoid insertion of unnecessary catheters and to remove catheters once they are no longer necessary. Quality improvement collaboratives that have addressed technical aspects of CAUTI prevention, such as avoidance of inappropriate catheterization, as well as team communication strategies have shown the benefit of this approach in decreasing CAUTI in both acute and long-term care settings. Antimicrobial catheters impregnated with silver or nitrofurazone have not been shown to provide significant clinical benefit in terms of reducing rates of symptomatic UTI. Evidence is insufficient to recommend suprapubic catheters and condom catheters as alternatives to indwelling urinary catheters as a means to prevent bacteriuria.